Welcome, everyone. We're going to wait just a moment for everyone to join us. But while we're waiting, we have a quick poll to help us get a sense of everyone in the room. You should see that pop up on the right-hand side of your screen. Thank you. Y'all can continue answering that poll as you enter the room. Diane, please go ahead and start us off for today.
All righty. Good afternoon, everyone. Welcome. We're happy to have you with us. The series of webinars have been developed as the NHSC's intentional steps taken to assist our NHSC members in becoming culturally competent clinicians through experiences and trainings in root causes of health inequities. That this will be valuable to you in your education of going to your communities and or prior to your communities. The purpose of the initiative, again, is really to give you that support organizationally, personally, and communicatively with your communities and advocation. I think advocacy is very important in your position at the sites that you will be going to. So I'm going to stop blabbing on. I'm happy to be here. I think we're going to have a great day together, and our speaker is going to provide you with so much information. And so I'll turn this back over to Sarah. Thank you so much for your time.
Thanks, Diane. We're so glad to have all of you joining us today. Welcome to Organizational Resilience Part 3, Efficiency and Support, the last webinar in our three-part mini-series on organizational resilience. My name is Sarah Gudema, and I'm Project Coordinator and Specialist at the Association of Clinicians for the Underserved, and I'll be your moderator today. We are particularly excited to have Dr. Christine Sinski join us today as our presenter. Dr. Sinski is a lead author on the National Academy of Medicine article, Organizational Evidence-Based and Promising Practices for Improving Clinician Well-Being. This article highlights the 6 domains that we have used as the foundation for our Organizational Resilience Guide and webinar mini-series. Over the course of this mini-series, we have explored strategies to prioritize workforce well-being by focusing on organizational commitment and utilizing workforce assessments. We have looked into building structures to evaluate leadership and engage clinicians in decision-making and policy reform. In this final webinar, we'll continue exploring means to support clinicians' well-being by focusing on workflow efficiencies and workplace peer support programs. All the topics we have touched on are meant to provide you with practical strategies that can help you grow a resilient organization, one able to adapt and transform to meet new challenges without compromising the health of your workforce. Addressing the underlying issues contributing to clinician stress and burnout places the focus of improvement on the system rather than on a single clinician. We hope you can continue to engage with this topic and reflect and improve on the experiences of those within your organization. With that in mind, I'm happy to introduce Dr. Christine Sinski before she shares her expertise with you all. Dr. Sinski is Vice President of Professional Satisfaction at the American Medical Association. A general internist, she practiced at Medical Associates Clinic in Dubuque, Iowa for 32 years. Dr. Sinski is a former director for the American Board of Internal Medicine and a former chair of the ABIM Foundation Board of Trustees. She currently serves on the National Academy of Medicine's Action Collaborative on Clinician Wellbeing. Dr. Sinski leads the initiatives at the American Medical Association to improve opportunities for joy, purpose, and meaning in work for physicians and their teams. Publications on the quadruple aim, joy in practice, texting while doctoring, and creating a manageable cockpit for clinicians have contributed to the national conversation. She has also contributed research regarding the prevalence, drivers, and solutions to burnout among physicians, and to resources for individuals and for health systems to improve practice efficiency and organizational culture. Before I hand the mic to Dr. Sinsky to get us started, I'd like to go over a few housekeeping items. This webinar is being recorded, and a link to the recording will be emailed to you within 2 days. The PowerPoint slides can be found on the webinar registration page, which we'll link in the chat now. Related documents are also available on the webinar registration page. We'll have time for Q&A at discussion points throughout the presentation and at the end, so please type questions you have for our presenter in the chat box on the right-hand side of your screen. You may have to manually open the chat box by clicking on the chat icon, which can be found in the bottom right-hand corner. If you need technical assistance, please contact our colleague Josh. His contact info will be pasted in the chat as well. To see closed captions, click on the CC icon in the bottom left corner of the webinar window. I'll hand the mic over to Dr. Sinsky to begin today's presentation.
Thanks so much, Sarah and Diane. It's a pleasure to be with you, and thanks to each of you for attending today and for the work you do in your day jobs, in your day-to-day work. I have to say I love the title of Organizational Resilience, and as we think about professional well-being for our clinical staff, our physicians, and our other clinicians, I think it's important that we move away from focusing on individual resilience to organizational resilience. And what does that mean? I think that means an organization that is resilient is an organization that is designed with all of the infrastructures within, the technology infrastructures, the policies, infrastructures, the staffing models are all designed to support and protect the individuals within. And so as we think about burnout, I think it's important that we recognize that while burnout manifests in individuals, it originates in systems. Burnout originates within the structures and the policies that our individual people are working in. And it's important that we focus on organizational changes rather than individual changes. So for the next almost 2 hours, I don't think it'll take us the full 2 hours, we'll be talking about 3 things: practice efficiency, and we'll talk about the practice fundamentals of workflow efficiency. We'll be talking about team building and teamwork, and we'll talk about some of the practice fundamentals of strategic delegation and sharing of care with an upskilled team, and the possibilities for improving our ability to deliver wraparound care to patients when we have a high-functioning, highly skilled team. And then our third topic will be thinking about a new lens through which to look at healthcare and through which to look at each of the decisions that we are faced with in our day-to-day work. And that lens is relationships. And this is based on this notion that over the last 20 years or so, I have observed healthcare to evolve to a very transactional understanding of the nature of our work. It's based on this notion that anybody will do, anyone can round on the patient, anyone can see the patient in clinic, anyone can be on the other side of the telemedicine screen. And I believe that at its core, our work in healthcare is founded on relationships, and that we are better clinicians, we are better at our jobs if we purposefully strengthen the relationships we have with each other, that is, with our team members and our colleagues, and if we strengthen our relationships with our patients. But that can't be dependent on just individuals trying harder to maintain those relationships. It's dependent on the actual decisions that are made, the infrastructures that are built, the policies around the technology and the physical space that will all either help or hinder the development of those relationships. So I'll also tell you that I'm going to be talking about the general topics that the slides might suggest, but we're not going to be following and reading off each slide. And so some of the slides we will have more discussion about and some less. And you can see the learning objectives that the organizers have put forth for all of us today. And as we think about the learning objectives, I'd like to have us move on to think about this. I want you to envision a pie, and envision a pie with 3 slices. And this is the Stanford Well MD model of healthcare, of professional fulfillment. One of those 3 slices is organizational culture. Another of those is practice efficiency. And the 3rd slice of that pie is individual resilience, or I have renamed that organizational support for individual well-being. So I think if we want to improve care that patients receive from our organizations, we really want to be thinking about how is our organizational culture supporting that? How is our practice efficiency supporting that? And do we have institutional support for individual well-being? And those 3 slices of the pie are what drive professional fulfillment. And when we unleash the professional fulfillment that our nurses and our physicians and our medical assistants chose this work with, then I think we will improve the care that our patients receive. I think it's also important to recognize that burnout is not a mental health syndrome. Burnout is an occupational distress syndrome. It is not a mental health illness. And so I think it's important at the outset to be really clear in our minds that when we experience the occupational distress of burnout, it is not that we have an individual weakness of inability to cope, and it is also not that we have a mental health illness of depression or of anxiety. So again, you can see that we're moving our focus away from individual resilience to organizational resilience, the organization that supports and protects the people within. And I believe we've had some links in the chat to some of the resources that have been created either from the National Academy of Medicine or from the American Medical Association. So we have a commentary called Creating a Manageable Cockpit for Clinicians, Creating Resilient Organizations. We have another commentary on Powering Up Primary Care. And then the National Academy of Medicine paper that Sarah referred to on organizational evidence-based and promising practices. I will also tell you that within that National Academy of Medicine paper, there are 6 domains that we refer to when we are thinking about how to improve the work environment and create more resilient organizations. And we have a companion program at the American Medical Association that we've created for organizations. There's no cost to this. And it's called the Joy in Medicine Health System Recognition Program. In fact, this came first, and then when I wrote the paper on evidence-based and promising practices for the National Academy of Medicine, we use the same framework. And I encourage any of you who have any leadership responsibilities at your organization to follow into the chat the link that takes you to the Joy in Medicine Health System Recognition Program. This is a program that has been used by many organizations as a roadmap or a guidebook for how they can move to become a more resilient organization. And we have 3 levels of achievement, bronze, silver, and gold, and 6 domains of activity, including assessment, commitment. So assessment, are we assessing the well-being of our workforce? Commitment, have we committed resources to advance well-being? Do we have a well-being committee? Do we have a leadership position responsible for ensuring that well-being is considered in all organizational decisions? And that could be a chief wellness officer. Do we have a strategic plan that includes addressing clinician well-being and healthcare workforce well-being? So assessment, commitment, practice efficiency is the 3rd domain, and we're going to be talking more about practice efficiency in a moment. And so we have criteria there in terms of how one might begin to measure and improve practice efficiency. The fourth domain is teamwork, which is tightly connected to practice efficiency, and we have specific criteria there. The fifth domain is leadership. And just to give you an example of one of the criteria for leadership, it's whether or not you de-implement some policies, whether you begin to look at your existing policies and recognize which ones may no longer be necessary and can be de-implemented and reduce some of the waste in healthcare and some of the burden that our healthcare workforce is laboring under. And then the sixth domain is support. And do you have peer support? Have you done other initiatives to build community within the healthcare workforce? So, and again, that program is the underlying structure behind the National Academy of Medicine publication that we've referenced. And it can be used by organizations and clinics that aren't going to apply for the recognition program, but just want that as a strategic roadmap. And we do have a nearly 100-page guide for how to implement each of those different criteria, so it can serve as a clearinghouse of information as well. So with that, let's switch over to thinking about the efficiency of the practice environment. And I want you to think of your own environments where you work, and think of something that's really working well in your environment, and then think of where the friction points are, where it feels like there's a drop-off in care, or there's redundancy, or there's just inefficiency and care isn't running smoothly. And I will share with you that it's my observation that most clinics in most specialties can save 3 to 5 hours a day for their clinician leaders and for their staff by re-engineering the workflows to eliminate waste, and by more strategically sharing the care among upskilled team members. And we have some resources. I see some of them have been put in the chat. One is a Saving Time playbook, and another is the Taming the EHR playbook. And to give you an example of some of the time savings, for example, we know that if physicians or other clinicians and their teams begin with some of the practice fundamentals, that we can save, if lab is arranged before the visit, so the patient has a lab done before they come for their appointment, they have their prevention lab and their chronic illness lab, that saves about 30 minutes of clinician time per day. If we do 90 plus 4 on the prescriptions, 90 days plus 4 refills for all stable prescriptions, then we can save another 30 minutes a day. In fact, we can save for many nurses who are responsible for managing prescription renewal, we can save 60% of their workday and redeploy that to more high-value work. So it's very expensive to use the prescription as the hook or the enforcer for making sure patients keep their appointment. It is much better to have other systems for encouraging adherence to the appointment, but not to use the prescription for that. Optimizing the physical space so there's co-location can save an hour a day for the clinical team. Taking a more team-based approach to inbox management and going upstream and reducing some of the inbox volume that's unnecessary can save 30 to 60 minutes a day at a minimum. So those are a few examples of some of the practice fundamentals that are available for organizations to implement. You don't want to implement all of them at once, but you can choose one. Start someplace and begin. And I would say the first place to start is proactively reappointing patients at the end of every visit. If health clinics and systems did one single thing and routinely reappointed all of their patients who are in a continuity of care relationship with their practice, that is not our urgent care patients, but patients who are coming to family medicine, internal medicine, cardiology, endocrinology, that sort of thing, reappoint each patient at the conclusion of each visit. That saves a lot of time and gets rid of a lot of waste. Then if you arrange pre-visit lab for all those prevention and chronic illness conditions for which you can actually predict the lab that you will need, then you save a lot more time because you can discuss those results face to face with the patient. The patient can be part of that decision making, and then you close the loop of care at the time of the visit, rather than the more common approach where people are sent for the lab after the appointment, and then the results trickle into the inbox in fragments, and then someone, the physician, the APP, the nurse, the medical assistant, is calling the patient afterward, giving them the results or sending the results through the portal. Then the patient may have questions that they weren't able to ask us. They didn't have an opportunity because this wasn't face-to-face, or a prescription is given and the patient says, I don't want that prescription. And then we get all these patient portal messages going around and around, and we have less safe care because we're not fully aware of that patient's entire situation when we're doing it remotely with our eyes closed, rather than when they're in front of us and able to be part of that decision with us. So as we go forward here, we're going to break soon to do a discussion section, and we're going to be thinking about some specific things that we'll be asking you to answer a polling question about how you approach some of those practice fundamentals, and hopefully that will help you think through your own work environment. I'd like to also talk a little bit about local autonomy as a driver of quality and safety. That when we involve the frontline workers in the redesign of the work that they are doing, we are actually involving the experts, because the people doing the work are expert in what their work is. And I believe that the more decision authority we push toward those clinicians who are closest to the patient, the safer the care can be, and the more satisfying and the more efficient. So some ideas in the chat are being, some links in the chat are being sent to some resources. One is a commentary on standardization versus customization. There is a tension between those two. And there are times when the standardized, predictable work should be just standardized, so you don't have to think about it. It just happens the right way by default. But then there are other times when we need to be able to customize at the level of the individual patient. And in many settings, we've put our healthcare workers into straitjackets with no ability to customize for the needs of the individual patient. We have a fear-based culture based on the lack of trust. And that's actually paradoxically causing a hazardous care environment for many. So it's also important to have feedback. And one of the best sources of feedback that, or structures for getting feedback, is something that was developed at the University of Nebraska called the Listening Campaign. And we have a Steps Forward toolkit on the Listening Campaign, and I see that that's put in the chat. And what happens here is that, again, it's the idea of let's listen to the people doing the work to find out what's working and what's not. And the way this is done is first at the University of Nebraska, where there's a chief wellness officer. That chief wellness officer meets with the chair of the department or the clinic lead, reassures them that these listening sessions are not venting, complaining sessions. And then the CWO, the chief wellness officer, and the facilitator host a meeting for 45 minutes or so, a meeting of 10 or 20 people from a unit. And they begin with individuals identifying what's really working great. That gets you off to a good start about thinking from an asset-based thinking point of view. And then each person makes a list of the things that they'd like to have be modified or improved. And then they discuss that with a partner, and then they discuss it in a large group. And then they each identify one wish. They put that on a card. People walk around and vote on the wish. And so then they end up with a prioritized list of things that unit feels from their expert perspective as the people doing the work would help them do the work better. And then the leadership team looks at that list and has now a prioritized list that they can work on in the next 6 to 9 months and get back with the individuals. Of course, some are feasible, some are not. Transparently, the leaders talk with the teams about that. Some of the things that have come up are a better scheduling template, a printer in every room, additional rooming responsibilities that the medical assistants or nurses can take on. So let's also think about another approach, and that's called getting rid of stupid stuff, or other people will call this getting rid of waste. It was started by a group in Hawaii. There was an article in the New England Journal of Medicine that caught the imagination of many physicians and other healthcare leaders around the country with the name Get Rid of Stupid Stuff. We have now a toolkit where the author of that New England Journal article wrote a step-by-step how-to guide. How you can solicit from your healthcare workforce things that may have made sense at one point, but either never lived up to their potential or are no longer relevant. And so you can prune those policies out of the organization. And that goes a long way toward improving the organizational culture and the practice efficiency. We have a related resource at the AMA called the De-Implementation Checklist. We've sent that to the Joint Commission. They've given us feedback, so we know that all the policies that we're suggesting a leadership group review and consider de-implementing are kosher with the Joint Commission and therefore with CMS. We have a debunking regulatory myths initiative. Online you can access, we have about 16 myths that help to debunk those myths and reduce some of that unnecessary burden that our teams are laboring under. So with that, let's go to the first polling question. And the polling question is around things that you can do to reduce waste and improve practice efficiency. And so you'll see that polling question in your Slido on the right-hand side. And I'm going to read what your options are. So with respect to visit note documentation, prescription processing, and order entry, are these tasks done, number one, only by the physician or APP in our practice? Number two, prescriptions and orders are pended or queued up by a clinical assistant or other team member, but still returned back to the APP or the physician for signature. Number three is prescriptions and orders are queued up by a staff person who also assists with composing the billing invoice, selecting the ICD-10 codes, and entering structured text within the visit note documentation. And then the fourth option is prescriptions and orders are queued up by the staff person who assists with the billing invoice and the diagnosis codes and entering structured task, and also helps recording the majority of the visit note documentation. Often this is done in real time when there's a collaborative care model where a nurse and the physician see the patient at the same time and share that care, or a nurse and a medical assistant see the patient together in a co-visit model, or some people call this a nurse-led model. So I invite you to vote on one of those four options. And it looks like of all those who have voted, the vast majority, which is 33%, if I'm understanding this correctly, all of those production line tasks are given to the physician or APP without much strategic sharing of that work with others. So I would say that shows an opportunity. If our physicians and APPs are spending their days doing work that doesn't require their level of training, that means our patients aren't getting the optimal amount of attention that they could from their physicians. It also means that our capacity is diminished because the team isn't working at full power, and so we are not able to offer access to some patients who are on the outside looking in. Well, with that, let's move on. And we will, let me just pull myself to, before we move on, we do have a few minutes for any questions that people have, comments, any discussion that people would like to add in at this point. What's working, what's not working in your organization around practice efficiency, or what questions do you have? And I'll have to be sure to ask Sarah, is this something that will happen just in the chat, or are people allowed to verbally answer their questions?
Yes, so people can chime in over chat, but if you would like to share your thoughts aloud, you can click the raise hand icon, which is towards the center right of your screen. And if you select that, we'll get a notification and we'll send you a request to unmute. You can go ahead and ask your questions directly.
And if there aren't questions or comments for this section, I'll just invite you, as you listen through the second session, to be ready to boldly raise your hand or put your question in the chat or your comment, and share your wisdom or your stumbles and struggles with the larger group. Because whatever it is, I'm sure someone else has either thought that or felt that same thing themselves.
Dr. Zinsky, we did also have one more poll regarding rooming staff at this point.
Perfect.
So go ahead and launch
Perfect. Yeah, thanks so much for reminding me. So let's do that second poll. So the second poll also gets at teamwork and how strong is our teamwork. So our rooming staff, whether that's our medical assistant or a nurse, do they, number one, bring the patient into the exam room and take vital signs, and that's the end of it, somewhat escort the patient back? Do they do that and also have a conversation with the patient about the reason for the encounter and at least identify what the chief complaint for the visit is? Number three, do they do both of those things, but they also proactively close care gaps based on standing orders and protocols? So that would be bringing immunizations up to date if they're due for a pneumococcal vaccine or a tetanus shot. Do they perform medication reconciliation? So do they do the initial review of the meds and see if the list that you have in your EHR corresponds with what the patient tells you that they're taking? And then do they gather any pre-visit test results obtained before the visit to make sure that that's available and aware and potentially brought into the visit note? And number four, do they review the previous notes and then ask the patient how they're doing with the changes? For example, we started on lisinopril, which is a blood pressure medicine, last visit. And do they ask the patient, how are you doing? Any problems with the cough with that? Do they provide self-management support? So if the pre-visit lab had shown the A1C had increased from last time, do they do some self-management support around diabetes with the patient? If the patient comes in and they're having, they have a history of asthma and they're having a flare, does the nurse or medical assistant perform symptom-driven testing by protocol? So in this case, would they be doing a PFT or maybe an exercise O2 stat? And after this more meaningful rooming process, do they provide a verbal handoff to the APP or physician to tell them what they've learned in the rooming process that will get the clinician off to the best start with the patient? And in the ideal situation, are there stable teams, the same physician and MA or the same APP and nurse working together day after day? So I invite you to answer those questions and submit your poll. And it looks like the majority of our respondents have the rooming staff kind of do the escort, find out what the go beyond escort, find out the chief complaint, as well as vitals, but we don't have as many doing care gap closure or self-management support proactively. And so there too, I think we have opportunities where care team members can provide more meaningful contributions to the care, which means that the patients get better care because those care gaps get closed by intention and by default by the way the rooming system is built. And then those patients also get the undivided attention of their physician or APP for the problem or the conditions that brought them in for the visit. So with that, Molly, if we're ready, we'll move on to the second section of our conversation today, unless anyone had any additional questions or comments. So if not, we'll move on to talking about teamwork. And of course, those two polling questions already started to think about what kind of teamwork is possible and what kind of teamwork is present in our environment. And I will just tell you, from my 32 years in practice as a general internist, the vast majority of those years we had the that advanced model of teamwork where the in our case they were nurses, were doing advanced rooming techniques and were staying in the room with us for many of the patient visits. And I think that that results in just really good care for the patient and a manageable cockpit for the physician. All right, so let's think a little bit more then about ways that we can improve teamwork and the sense of teamwork. And we've got so I want you to think in your own minds and think about your own practices, about the nature of your teams. My own observation is that most teams are seriously underpowered, and they're underpowered for three reasons. The first one, and the easiest to remedy, is lack of team stability. We know that if the same medical assistant and physician, or the same medical assistant and APP work together, the quality is better, the costs of care are less, and the capacity is increased. There was a study from the Chicago area where simply pairing those healthcare professionals together in stable relationships, they increased their capacity by 11%. So they didn't add more staff, they just prioritized having the same two people work together each day, and that improved their outcomes. So stability, same people working together. Skill level. Have we invested in training up our medical assistants or in hiring LPNs or associate's degree RNs to be contributing members of the team? And then size, the structure. In my experience, 1/2 medical assistant per physician or APP is simply not enough. And it's not possible to deliver optimal care under that situation. You will have capacity to see a much smaller panel of patients. You'll have much less same-day access to provide continuity. And that ideally, the ideal model is 2 MAs per physician or 2 nurses per physician. Another way to improve teamwork is to create opportunities for team connection. I know I've visited practices where the medical assistant and the physician would hardly see each other at all throughout the day. And I've had physicians tell me, I don't really know my medical assistant. I mean, I know they come in and they do their vitals and then they go, but I don't really see them. And so simply locating the medical assistant and the physician near each other is a way that you can build trust and reliance between those people. And it's a way that you can save a lot of time, because if you can ask questions of each other, if you can address patient concerns through a voice-to-voice, face-to-face communication, that's a lot more effective. It's a lot richer form of communication than if you're dependent on sending asynchronous messages through the electronic health record or through secure chat messages. So the opportunities for building real teamwork need to be built into the physical structure. Are we sitting near each other? Into the culture. Do we have daily huddles where we get together for 5-10 minutes at the beginning of the clinic session and say, who's here today, who's not, who's got stresses outside of work that are kind of bringing them down a bit in their game, and ask forbearance from the rest of the team. We can do that better for each other if we know what's going on. And perhaps which patients on the schedule are going to have some special needs, and we just want everyone to be aware of that ahead of time. That 5 to 10 minutes of level setting among the team can make the team work much more smoothly through that session. Then there's another form of communication called a mini huddle. It's the warm handoff. So the MA has roomed the patient. In the best situation, the MA doesn't just plop the patient down and take the vitals and ask what the chief complaint is, but they have a conversation and they find out a little bit more about how things are going for that patient. I always ask my nurses, give me something medical and something social. Something medical means how'd they do with that metformin that we started last time? Did they have diarrhea? Did it bother them in any way? And something social. And that way I would learn if someone important in the family had just died, I wouldn't come skipping into the room all full of cheer and really mismatch the emotional tone of the patient. And vice versa, if perhaps the patient had just visited their granddaughter and had a wonderful time, I might begin the visit by saying, hey, do you have any pictures of your granddaughter on the phone you want to show me? And by doing that, I learned more about the patient, and it would often use then in the rest of our clinical visit. And so those few minutes of the mini huddle, and then those few minutes of social conversation with the patient actually save minutes in the long run. Then the third area of communication to improve teamwork is having team meetings. And team meetings are something that different organizations do differently. What we did in my own practice was every 2 weeks, the core team of our pod or our hallway within a much larger organization of 2 physicians, 5 nurses, and our nurse manager would meet. And we would meet during the workday for the nurses, so it was on the clock, but we would meet away from the clinical space in a conference room down the hall for an hour. And we did that every 2 weeks. And the objectives were to build stronger teamwork and stronger processes, more trust and reliance among each other. So we had a check-in, about 10 minutes to go around the room. What you do this weekend, what's going on, what's important, what are your joys, what are your sorrows. People could choose to share whatever it was that they wanted, but over the course of months and years, we got to really know and frankly love each other because of that greater knowledge. And that meant that it was just easier to work together. Then we had a section on checking back. How did the decisions we made last visit about improving our workflow, how are they going? Do we need to tweak anything? And then we'd address one element of our workflow. If we were going to initiate a new process, then we would want to get everyone's input. So if you're going to start a new process of reappointing every patient at the conclusion of the visit, you don't really want to just begin with that and just make a dictum that that's how it's going to be. You want to work with the team and make sure that every role type has had a chance to give input. And then at the individual team level, that every team has had the chance to digest this and process it and make sure that the practice is one that fits everyone's needs. And then we would have a section at the end of the team meeting on a clinical update where we would teach on a topic that the staff wanted to learn more about. And the staff would often be the ones who would suggest, yeah, I want to learn more about sleep apnea. Or, you know, there are new diabetic meds. Can you give us an update on those? Or what's new with mammogram screening guidelines? So I think with this now, we are ready to move to our next poll. And our poll is around some questions around team function. And so if Sarah or Molly or someone can put that into the Slido in, we'll have two sets of questions here. The first one is, in our practice, the physicians, APPs, and staff, number one, come to work, do their job, and go home. Number two, know the other people in their same role and support each other. So the MAs know each other and have each other's back. Number three, every member of the care team shares ideas and suggestions with others in the same role, but also others on their larger team. Or number four, those who work together have gelled as a practice team that has an identity as a team. They meet regularly, they have good communication, even on difficult subjects, or when there's a difference of opinion. So I welcome you to submit your polling answer. And here we've got a lot of optimism about teams. It sounds like we've got some really strong teams where there's good opportunity for communication. It could be a reflection of the number who had a chance to answer, because we also have a good number who might be saying, not so much. So I think the good news here is that there's a decent amount of teamwork that is expressed by the representatives of different organizations here. So I think we're ready to move on to that second question. And this is around, how do we not only do today's work, but work to make tomorrow's work better? How are we constantly trying to make those small adjustments so that the friction is taken out of the day, to get rid of those pebbles in the shoe? So with respect to improving the way we do our work, number one, we don't really have a formal structure for improving our work. We just come to work. Number two, we have a multidisciplinary team that creates new workflows and then shares them with others. And it's sort of a design and deploy idea. We design it over here, and then we decide that that's the best route, and we give it to you, and then you carry it out. And the third is, we have some sort of framework. We might use the Lean framework or some other kind of framework. And then we have a quality improvement champion and a multidisciplinary team. And we include frontline workers in the redesign of their work. And number four is that everyone in the organization has been trained in one of the quality improvement approaches, and we all share the language and tools to shape our problem solving. And we routinely shape or assess our workflows to ensure that the things we've done are actually improving patient care. So go ahead and put in your votes there. And as you're voting, I'll share that I have visited an organization, Theta Care in Wisconsin, where they adopted Lean. And it was so remarkable to go there, because everyone from the scheduler to the medical assistant to the clinic manager to the clinical people, they spoke the same language, and they didn't talk about the doctor's work. They talked about the team's work. They didn't talk about the doctor's patient. They talk about the team's patient. And I think that their use of that shared language of lean helped them improve their culture and create a more resilient culture. So I'm going to pause here and again invite anyone who's interested to share what's worked well for you. Where are your challenge areas when it comes to teamwork?
As a reminder, if you'd like to speak, please feel free to click the raise hand icon and we can bring you off mute. And you can also feel free to use the chat as well.
What's holding you back? I think in many practices, the engine of healthcare is working at half power. And it's working at half power in part because we don't leverage the power of our stable teams. Well, we have a lot of people who are thinking quietly to themselves, and that is okay as well. So with that, why don't we move on? And our third section, and I do see one question in the chat. We've assembled a multidisciplinary task force to move the needle on this. We started with leadership training for this task force. Well, absolutely. I think making sure that the task force is aligned on change management strategies and communication strategies is really a very first step. You can really undermine a great idea by not having people aligned in terms of the language we will use, the approach we will use, the importance of getting buy-in from those who are going to be affected by the changes. I think the last thing that most people who come to work every day want is to have something done to them. And so if the culture is one of top-down design and deploy, command and control, and people feel like they're being done to, they're just told what to do, it's a very different work environment than if you're in an environment where it's a empower and encourage and co-creating some of the solutions. Now, you can't have complete chaos, so you do need structure, and there are times when you need to come to a decision, and this is the standard way we're going to be doing it. But I think more often there are opportunities for local customization, and making room for that is important. I invite anyone else who's had any experiences, positive or negative, around change management and leadership training to add your thoughts, either verbally or in the chat. And again, nothing wrong with silent listening. Let's move on. And we're going to talk about peer support. And we're going to talk about peer support in a high-level view about relationships, and then in a more specific, granular view around peer support. And so let's first talk about relationships as an organizing principle for healthcare. And I strongly encourage you to review the Mayo Clinic Proceeding article that I was fortunate enough to co-author with two others on the radical reorientation of the U.S. healthcare system around relationships, rebalancing the transactional model. and share with you that I believe that reorienting our clinical work area, our larger health systems, our largest US healthcare system around relationships is the shortcut that we can take to achieving quadruple aim outcomes of better care experience for individual patients, better health outcomes for populations at lower cost, while facilitating joy in work for our workforce. And I think that if we start to look at healthcare through that lens of reorienting around relationships, we will provide better care. And so I'm going to ask you to imagine with me a patient. And the patient is Mrs. Petty, and she calls into her doctor's office saying, I'm having a problem and I'd like to see my doctor, Dr. Sarah, today. So she knows that the best thing for her to do is to call in before whatever the problem is accelerates and becomes a bigger problem. When she calls in, the receptionist says, shucks, the last appointment for today for Dr. Sarah just filled, but good news, Dr. Bresnik can see you, and he can see you at 1 o'clock this afternoon. In most organizations, that is an unqualified success. The patient called in, she was seen the very same day by someone in the practice. But I want to ask, is that as good as we can do? Is that really good? On the surface, it seems good, but looking deeper, there's a lot of waste in that model. So the patient sees Dr. Bresnik, who's never met her before. She has a moderately complex medical and surgical history. He struggles to get modestly up to speed, spends most of his time looking at the screen, trying to sort out what med she's on, what tests she's had done recently, what medical illnesses she's had. He spends about 25 minutes in the room with the patient, orders several tests, applies a few temporizing measures, and sort of says, well, I think that's the best for today, and I can arrange for you to see your doctor, Dr. Sarah, in 3 days. Meanwhile, Dr. Sarah is down the hall, overwhelmed with administrative work. She's putting in orders for labs, she's sending prescriptions to the pharmacy, she's typing up visit notes, and she is spending, as we know from studies that we have done, 2 hours on EHR and desk work for every 1 hour of direct face time with patients. So again, many would still, though, think that that was a reasonable outcome. Patient saw somebody on the same day. But think about all the waste. Now we've got 2 appointments rather than 1, which doubles the work for the patient, for the reception staff, for the billing staff, for the rooming staff, for the physicians or APPs, and it may result in unnecessary testing and unnecessary hazard for the patient. And that's a vicious cycle where waste at every point along the way contributes to more waste because we've reduced the capacity. And I believe by focusing on relationships, we can turn that around and create a virtuous cycle. If we combine prioritizing relationships and continuity with operational efficiency, like doing pre-visit lab and 90+4 on the prescriptions and expanding some of the rooming responsibilities that are shared with our staff, then with those 2 as foundational, we reduce the total amount of work that's required to take care of the same number of patients. But when we reduce the total amount of work required to see the same number of patients, we've effectively increased our capacity, which means we've increased our access so that those patients who do call in are more likely to have continuity with their regular physician. And we can offer entrance into care to some of those people who've been otherwise standing on the outside, unable to get in. And so relationships, I believe, are our superpower. And those relationships are those with our team and with our colleagues. That's how we work more efficiently, and with our patients. And that's how we deliver more care, and we can deliver that care more efficiently if we prioritize continuity. I also want to share that relationships with our colleagues and with our team members are important. They are a source of support during times of individual or collective crises. Anyone who's had an illness or a family crisis and your coworkers are well known to you, you're well known to them, you trust them, they can be a tremendous source of support. If there is a collective crisis, a COVID-19 pandemic, and we already have team members who know and trust each other, then we can work together more effectively for our patients. When an individual patient has a crisis, and the nurse in internal medicine who's known that patient for a long time can call up to the nurse in oncology and say, Mrs. Smith was recently diagnosed with breast cancer, and I also want you, and she'll be seeing you tomorrow, but I also want you to know these are the other important aspects of her life. And if you know those, you will be better able to tailor the care to her. And those kinds of communications, they don't take very long to do, but they make a big difference to the experience of care, not only for the patient, but for the other individuals. Those two nurses had a better experience of care because they delivered great care to that patient. So how do we develop that peer support? Some of that is through the physical structures and the policies and practices. Do we have team meetings where we get to know each other? Do we have those daily pre-clinic huddles? Do we do a mini huddle before we enter the exam room? Do we have enough flexibility in the day, enough breathing room in the day that we can look each other in the eye and be aware of what's happening? Or are we just transactional? The MA rooms that patient, they're back to their station, the doc comes in, and they never even talk to each other. So a number of slides that we're going to just go over about peer-to-peer support, and then I'll share with you some ideas and practices that I have seen that have been quite helpful for others. Many of you know about Schwartz rounds, and that's a good way to build culture where individuals come together to talk not just about the medical aspects of care, but also about the emotional and ethical and social aspects of care. Another variation on this theme that is a practice back from 40 years ago, but in the past, a grand rounds might include a master clinician interviewing a patient and their family, or a patient by themselves, as part of the grand rounds experience. And by doing so, demonstrates their mastery, that the demonstrates and models good communication with the patient, demonstrates compassion and empathy with the patient. And I think it helps the culture of the entire organization recognize that patients are not just illnesses, but they are people with full lives who happen to have an illness. And there are trainings that are available. One of the things that I find most helpful is collegial dinners that have been set up at various organizations. And one of those dinners, this was started at the Mayo Clinic, and at the Mayo Clinic, physicians could gather in groups of 10 to 15 physicians, and they had a mechanism for people signing up and being assigned to groups. And they would agree to meet every 6 weeks for an inexpensive dinner at a restaurant in the area. And the commitment was that they would spend 15 or 20 minutes discussing a discussion question that was given to them in advance. And they would then spend the rest of the time either discussing that question if things were going well, or having a social conversation with each other. And the commitment was to do this every 6 weeks for a 6-month period. And when they studied this, they found that there was a lasting benefit, that even 6 months after the conclusion of the intervention, there was a 15% decrease in burnout and an 8% decrease in intent to leave among those physicians who had been part of one of these discussion dinner groups 6 months earlier, compared to the controls who had not been part of that. Now we know it costs between $500,000 and $1.4 million to replace a physician who leaves the organization. So if you can have an 8% reduction in the physician's intent to leave, then we know that that has massive consequences for the bottom line for that organization. At Mayo, they refer to the cost of these dinners as budget dust because it was so small relative to the larger budget, but also so small relative to the gains. 15% decrease in burnout means a lot lower cost of care, a lot less turnover. Another kind of peer support that I'd like to highlight is one that, and we have some peer support resources at the AMA. And one peer support is called Peer RX MD. And if you Google Peer, PEER RX MD, you will come to a website that was put together by a family physician at Clinicians Clinic, which is in the southeast of the US. And people can sign up with a buddy, and then they will get a text message every week reminding them to just check in with that buddy about how they're doing. And the message may also come with a dimension to be thinking about, some question they might want to discuss with their buddy, or just something they might, a particular aspect they might want to check in with each other about. And this was started before the pandemic, but became really quite useful at the time of the pandemic. We also have a Steps Forward toolkit written by Dr. Joe Shapiro, who is a national expert on peer support. She had been at the Brigham, I believe, and now she is at the Massachusetts General Hospital. And I would encourage you to look at that peer support toolkit that she's put together. She's also given a webinar for the AMA, and that's recorded and is available at that same toolkit, so you can learn by reading or you can learn by listening. At the beginning of the pandemic, we worked with 2 individuals from the military, and those 2 individuals wrote a stress first aid toolkit. I apologize, there is loud noise in the ambient environment here. I'll depend on Molly or Sarah to let me know by chat if that's impacting your ability to hear. We have a stress first aid toolkit that was written. It was a nurse and a physician who were dealing with servicemen and servicewomen who were experiencing PTSD in the military. And I think what we'll do is let's go to our discussion question. Okay, so here we have 4 or 5 more options with respect to professional well-being. In our organization, we don't specifically address well-being or burnout. Number 2, we have a wellness committee. Number 3, we have a wellness committee, and we do an
and practice with confidence. Please make sure you're registered, and we hope to see you then. Goodbye, everyone.